Hi, everybody. This is Dr. Bulut, and I'm a medical doctor, and I'm currently working as a specialty doctor in psychiatry in Essex Partnership University NHS Foundation Trust in the UK. And thank you very much for the invitation to this conference. 9 months ago, when we were in the clinic, we saw a patient, and this patient has some distinct features from our other patients. And today I'm going to discuss with you about this case, and this will be a case presentation. And we wrote a case report about this presentation, and with Dr. Adrianjo and Dr. Marley. Now, before I start my presentation, I want to ask questions to everybody. And can I closing really help with hallucinations? If you have an answer, please feel free to tell. If there is no answer, we'll see the answer with the presentation, and we'll answer it later. And in this presentation, this is the content of the presentation. Firstly, we're going to talk about background of our patient. I'll give you some information about the diseases that she has. And then we'll talk about the case description of our patient. And then later we will have a discussion part, and we'll try to explain the possible mechanisms for the presentation. And at the end, we'll have a conclusion part. Now let's talk about the background of our patient. Our patient had a giant cell arteritis diagnosis. And maybe you heard this giant cell arteritis before. It's also known as temporal arteritis. Giant cell arteritis is a chronic form of vasculitis of the large and medium vessels of carotid arteries. Mainly, it involves the carotid arteries and the external branches of the carotid arteries. As you can see in this picture, you'll see the temporal artery. And when it involves the temporal artery, it can present with tenderness. Sometimes giant cell arteritis present with other symptoms, as shown in this picture. Many people are diagnosed with giant cell arteritis after presenting with visual problems. Mainly, it is just visual loss, sudden and visual loss. Unusually, giant cell arteritis may involve the smell and hearing alteration, which may therefore be a diagnostic relevance. Now, giant cell arteritis symptoms are mainly sudden and deep vision loss and headache. Sometimes they can present with scalp tenderness. Sometimes they can present with jaw claudication, muscle aches, fever, and weight loss. When they present with jaw claudication, sometimes people may feel like tooth pains, and they can go to the dentist for giant cell arteritis. And in this picture, you'll see optic neuropathy because of giant cell arteritis. And there's a disc edema as shown in this picture. And also there are some hemorrhages and cut and wool spot. This is a diagnostic picture of the giant cell arteritis. This. And giant cell arteritis is mainly treated with steroids. And steroids may result in steroid-induced psychosis. That in turn can occur at lower doses in the older adult population because of the pharmacodynamic and pharmacokinetic effects of medications. And with the steroid use, it can present with just subtle mood changes like anxiety or distractibility. And some people experience memory deficits, and even worse, they can present with just psychosis. And we report here on visual hallucinations in the context of an exacerbation of GCA. And that's treated with the high-dose steroids. And she also had comorbid cataracts, which was newly diagnosed. And one of our authors, Dr. Damola, asked, find an intervention, and that proved effectively in transiently alleviating the symptoms of this patient. Now, let's talk about the case description. Our patient was a 65-year-old lady, and she presented to emergency department with the suicidal ideation and anxiety. And when we check her, in her past medical history, she had post-polio syndrome atrial fibrillation, giant cell arteritis, newly diagnosed cataracts, and hypertension. And then she was referred to our older adult home treatment team. Our team provides intensive psychiatric treatment in the community. And we usually see patients who are older than 65 years of age. They mainly have psychiatric problems. And when we check her medications, only prednisolone was associated with the hallucinations, and the other medication wasn't associated with hallucinations. And when we come to her hallucinations, she reported visual hallucinations that were in the form of animals, a man, and faces. An example of the animals were rats that were sometimes the size of beavers, like this in the picture. And the rats were usually seen peripherally running across the floor. There were also more general descriptions of animals, and these were both stationary and moving. She also reported that seeing a standing man inside the house. And she also reported seeing faces on her bed or on the wall, looking at her approximately once a week. And the faces would mainly happen in poorly lit conditions. And sometimes they would be very clear, and sometimes they would contort easily. And in her personal history, she was living on a farm when she was a child. And we think maybe these past experiences influence the hallucinations that she's experiencing. Firstly, we thought this was a giant cell arteritis exacerbation, and we thought that maybe steroid titration might help this patient. And we increased her steroid dose. And with the steroid titration, she started experiencing olfactory hallucinations, and that were described as like a burning smell or cigarette smoking inside the house. But these are reported less frequently. There was also a report of auditory hallucinations, such as like a crashing sound. And then we thought decreasing the steroid dose of this patient, and we monitored the response to a reduction in the steroid dose, which was gradual, and it was associated with a slight improvement in symptoms, but although it was still distressing for this patient. And one of our Dr. Damola, when she was asking her if she knows anything about the aggravating or relieving factors, and our doctor asked her if she can still see the hallucinations after closing her eyes. And she asked her to do this every time when she sees hallucinations. In the next appointment, she reported that whenever she closed and then opened her eyes, she would no longer experience the visual hallucinations of animals and faces, and she was consequently less distressed at those times. Now, let's talk about the discussion of this presentation. Visual hallucinations are an important clinical feature of temporal arteritis, and this may precede the ophthalmologic emergencies. Sometimes people may start having hallucinations, but usually they don't know that they have giant cell arteritis. But usually they come to emergency department with the visual loss. In one case report, visual hallucinations improved after the initiation of systemic steroids. In this case report, the patient was treated with 30 milligrams of prednisolone for acute deterioration of vision for 4 months. And she had immediate relief after the treatment. And after that, prednisolone dose was gradually reduced and stopped. And she was symptom-free of hallucinations and her giant cell arteritis. And her laboratory results proved this, and her ESR level was 5 mmHg. Although the mechanism of steroid-induced psychosis is unclear, synthetic steroids mediate mood disorders by disrupting the balance in the hypothalamo-pituitary adrenal axis. by activating the glucocorticoid receptors and suppressing the adrenals from steroid production. According to one study, psychiatric disturbances can occur at any point during corticosteroid treatment, including almost immediately after initiation as well as after cessation. And our case was completely different from our other patients because we've never seen like this before. We usually see patients with hallucinations, but they don't usually improve after closing their eyes. And we read the literature for similar experiences. And in a review of 70 case reports, Lewis and Smith found a median time to onset of 11.5 days. And 39% of disturbances occurred during the first week, and 62% within the 2 weeks, and 83% within the 6 weeks of treatment initiation. In another report of 14 cases and review of the literature, Lewis and Smith found that severe psychiatric reactions occur in approximately 5% of steroid-treated patients, and that a large proportion of these patients have affective psychotic symptoms. And in a review with a case report, an 85-year-old patient with temporal arteritis started to use prednisolone 60 milligrams per day due to permanent loss of vision in her left eye. And while reducing the prednisolone, she started to experience depressive feelings, anhedonia, apathy, poor concentration, suicidal ideation, and hallucinations. And subsequently, she was hospitalized due to aggressive behavior toward her 24-hour carer. Maybe some of you heard Charles Bonnet syndrome before. In our case, our patient also had cataracts, and that was newly diagnosed for this patient. And cataracts resulting in visual impairment can lead to the well-described Charles Bonnet syndrome, and that may be important with our case. Charles Bonnet syndrome is a condition that some people get when they lose some or all their vision. It causes them to have visual hallucinations. They start to see things that aren't there. But usually these patients do not experience other type of hallucinations like auditory or olfactory, which our patient had this when we titrated her steroid dose. She started to experience burning smells and cigarette smoking in the house. And now let's talk about the mechanisms of this presentation. And we suggest 5 possible mechanisms that may account for the hallucinations. The first one is release phenomenon. And the second one is deafferentation. The third one is conscious effect. And the fourth one is Guesthouse psychology. And the fifth one is ischemic exchanges. We wrote these mechanisms after reading the literature. And first one is the release phenomenon. According to release phenomenon, any deprivation to visual system interferes with normal circuitry that inhibits activity in visual association cortex. The lack of inhibition will result in inappropriate excitation of visual association cortex, and that subsequently cause visual hallucinations to be released. Now, the second mechanism is the deafferentation. In deafferentation theory is not a theory, it's a hypothesis that is most widely accepted to explain Charles Bonnet syndrome. And deafferentation means loss of visual input to the brain will lead to the change in excitability of visual association cortex. In this theory, loss of visual input to cortex increases the excitability within the associating cortex and resulting in spontaneous neuronal activity and visual hallucinations. Now, the third mechanism is the conscious effect. Absence of conscious inhibition of hallucinations may explain our case. And this is happening by closing the eye. And maybe closing the eye interrupts the sensory input and misperception. And this may support a conscious overriding of subconscious perception. And also in a case, there is evidence that this functional inhibition of memory may have a role in auditory hallucinations in schizophrenia. Now, the fourth mechanism is the Gestalt psychology. Maybe you heard this one before. With the Gestalt phenomenon, the brain derives meaning from all of the sensory input. In our case, incomplete sensory input due to cataracts may result in unpredictable pattern completion, resulting in visual hallucinations. And with the closing and reopening the eyes with a slightly altered head position may result in distinct but still incomplete sensory input with different results for pattern completion. And now there is a case, an example with the phantom limb syndrome. In this example, the manipulation of visual information resulted in resolution of pain, perhaps using a similar pattern completion mechanism, but this time integrating nociceptive and visual information, perhaps at the level of the association cortex. Now, the fifth mechanism is the ischemic exchanges that we explained. Usually, temporal arteritis supplies the retina and optic nerve, and ischemia may result in visual dysfunction, leading to hallucinations. Eye closing may result to demands on the optic nerve and the retina, and it may provide an opportunity for recovery in the context of a compromised blood supply. In one case report, this case report actually is similar to our case. And in this case report, 68-year-old patient with Charles-Bonnet syndrome was diagnosed with non-arteritic anterior ischemic optic neuropathy. And that patient had similar visual hallucinations to our patient. And this patient experienced monocular visual hallucinations in the left inferior part of the visual field. And this results with covering of the affected eye and allowing other eye to compensate. Now, we spoke with the discussion part and we spoke about the mechanisms, and we come to the conclusion part. It's quite difficult to differentiate between steroid-induced psychosis and hallucinations due to progression of giant cell arteritis. And hallucinations seen in the later stages of the disease may precede terminal visual loss. And in our case, our patient had an ophthalmologic review 2 months prior to the initial presentation to our services, and that revealed her GCA was stabilized with the prednisolone at that point. The alleviation of the visual hallucinations with eye closing needs further investigation, and maybe with further case report, it may be possible to explain impact of eye closing on visual hallucinations in giant cell arteritis, steroid-induced psychosis, Charles-Bonnet syndrome, or all. Now, this is a paper of our case. We published this in the Journal of Psychiatry, and Dr. Adeyanju was the first, and I was the co-author. And these are my references. And thank you very much for your attention. If you have any question, I'm happy to answer it.
Thanks for your presentation. Now floor is open for the questions. If